Good morning and welcome to our Rhinitis and Conjunctivitis Allergy Education Workshop. This is the second session in the series. My name is Megan Ahmad. Thank you for joining us today. I would like to thank our sponsors for making this event possible. For any queries, please email admin@allergyfoundation.co.za. The recording of today's webinar will be available to anyone who's registered. You should receive the recording link by Monday afternoon. Our program today will be led by an awesome panel of experts. We have Dr. Peter Deval, Dr. Sharani Naidu, and Dr. Abina Dlakavu. For any medical professionals in the audience, please note that this is not a CPD event. Before we get started, I'd like to go over some basic housekeeping. This is quite important, especially for those joining us for the first time. This is to ensure that you understand the icons. You'll notice a taskbar in the top right-hand corner of your screen. Our audience is muted and will remain muted for the full duration of the session today, and we will not use the hand up function. Instead, we encourage you to post your questions in the Questions tab. Our panel of experts will answer questions during and after the talks and in the Q&A session at the end of the webinar. You may use the React button to interact with the panel by sending your reactions. Today's program and other content may be downloaded from the Materials tab. We are excited about this Allergy Education Workshop series, which is specifically aimed at patients, parents, caregivers, educators, and those wanting to learn more about allergy management. Our next session takes place on 19 July with a focus on asthma. These sessions are free to attend. I've included the slide in the Materials tab. Please feel free to download and share. Email admin@allergyfoundation.co.za for more information. Follow us on social media and sign up for our free newsletter to receive updates. On the screen is the registration link to attend the next live allergy education workshop, as well as the link to the MP4 on asthma. Please visit our website, which is www.allergyfoundation.co.za, to learn more about what we do and what we offer. Sign up for our newsletter, browse our articles and free downloadable content, and explore the products under the AFSA seal of approval. Visit the AFSA shop to purchase our in-house products, such as the AfriSpacer device, which is to use with an inhaler, and the Kitty Calmware range of eczema clothing for children. And lastly, before we continue with the program, I'd like to mention that we have prizes up for grabs today: a Beat Allergy pack from Mrs. Martins, valued at 500 Rand, and a Salix hamper valued at 1,000 Rand. Winners will be randomly selected and announced live at the end of the session today. Please allow me just 1 minute to play our promotional videos. Thank you so much.
Looking for products that are safe for allergy sufferers? The AFSA seal of approval is here to help. This trusted seal is awarded to products that comply with our strict quality criteria. Look for it on body care products, air conditioners and purifiers, medical bracelets, nasal sprays and washouts, eczema clothing, cleaning products, and many more. Choose your products with confidence. Look for the AFSA seal of approval or visit allergyfoundation.co.za to view the available products.
Thank you so much. Dr. Dlakavu, welcome. Sorry. That's awesome. Dr. Naidu, Dr. Dlakavu is here, so we're going to have her start with the first talk. Awesome. You are muted at the moment, Doctor. Good
Good morning,
morning.
everyone. Apologies for the late start. Is everyone seeing my screen all right?
That's perfect.
Thank you. My name is Abina Zagavu, and I will be talking about identifying and treating allergic rhinitis. Thanks for joining us this morning. So to begin, we'll be talking about what allergic rhinitis actually is. And I think quite generally, people tend to use the terms sinus when they're talking about this condition. Some people say hay fever, and we're actually all talking about the same condition, and that is allergic rhinitis. So if we break it down, rhinitis itself refers to inflammation of the nasal passages. But then when we're talking about allergic rhinitis, that means that that inflammation is due to exposure to an allergen. And what that inflammation causes is that you get swelling and increased mucus production in our noses. So where this commonly happens for us, so we normally have quite brief episodes of rhinitis. We all know we get a runny nose when we have a flu-like illness. And at this time of the year, this is very common. Whereas with allergic rhinitis, this is actually a chronic condition, and it tends to be quite long lasting. And although it's very prevalent and lots of people do live with this condition, it's actually not a trivial condition, as some people might think, and as it has actually quite significant impacts on people and patients' quality of life. So just to put it into context, so when we talk about rhinitis as a whole, so I've said rhinitis is any inflammation of our nasal passages. So it could be of an infectious nature, as I mentioned, potentially like flu-like illnesses, or non-infectious. And then when we look at our non-infectious causes, that's where allergic then comes in. So it could be allergic or non-allergic. So this, I've just put this in just to demonstrate that there's lots of different other causes, but this is where we're going to be focusing, just the allergic rhinitis. This image here is for us just to demonstrate where we're saying the problem is. So if we look at the top, on the left-hand side of the screen, this is what our nasal passages look like when we don't have any illness. So you'll be aware that we have these passages here in the nose. These are called turbinates, and generally the airflow travels in these spaces around the turbinates. But now on the right-hand side, this is someone who's got swollen and inflamed turbinates, as you would get in allergic rhinitis. And you can appreciate then that the space for the airflow is significantly lessened. So that's why you then struggle to breathe properly, and you've got that feeling of fullness. And while we're on the screen, I must just draw attention to what's next to our noses. So on either side, this is where we have sinuses. So you can appreciate that when we're talking about rhinitis, we're talking about a problem in the nose, whereas sinus problems are outside the nose, but you can see how they're closely related. Then to the bottom of our screen, again on the left-hand side, this is what it looks like in the normal undiseased state, where we've got those passages that we could see at the top. So we've got our inferior turbinates there and our middle turbinates, and we'll have airflow going in from our nose, from the front of the nose down. And on the right-hand side, where we have allergic rhinitis, oh, I'm so sorry. Apologies for that. Apologies for that. So on the right-hand side, you can see that the turbinates there are swollen and there's a lot of exudate there, and that would impair the airflow. So when we go on to talk about what symptoms we would get with allergic rhinitis. So as we've said, that it's inflammation of the nose, so we'd expect that the bulk of the symptoms will be affecting our nose. So there'll be quite a lot of discharge. You'll feel blocked. Sneezing and itching are quite prominent symptoms as well. And then the post-nasal drip. So we've said there's quite a lot of mucus production. So some of that mucus will come out anteriorly, so you'll blow your noses, but some of that mucus will drip backwards. So some people might have repeated like throat clearing noises that they make, or they actually might even have a bit of a dry cough as a result of a post-nasal drip. You might also get loss of taste as a symptom, or because you've got that congestion, you might have some facial pressure or even have a bit of pain. But the symptoms aren't confined only to the nose. So our eyes are quite close by. So you can also get some itching and redness of the nose, and you can actually feel like there's bits of grit or dirt that's in your eyes. Or some people have sensation where they wake up and they actually wake up with swollen eyes. But there'll be more about the allergic conjunctivitis in the next talk. Our throats can also be affected, so you can get itchiness in the throat. And sometimes you'll hear people who, when they have their symptoms of the rhinitis, so they've got the itching of the nose, so they're rubbing their nose. Then sometimes people are excessively rubbing their ears as well, because it feels itchy deep in their throat and also deep into their ear. Then you can also get a soreness in the throat or a hoarse voice. I've added here that sleep is also affected. So this is something that's quite significant because there'll be some significant mouth breathing because you've got the congestion of the nose, and this can be quite pronounced during sleep and cause snoring. And if your sleep is severely affected, then obviously you're not going to be performing at your best during the day because you haven't had good quality sleep. So these are some of the symptoms that we'll be looking out for to say someone has allergic rhinitis. And what we might see, so this picture here, we've got a child with allergic rhinitis, and these are some of the features we'd be looking out for on examination. So I've labeled this as atopic facies. This is generally what we'd see in a child who has atopic conditions. So the things that tend to go together being allergic rhinitis, eczema, and sometimes with asthma as well. So the allergic shyness refers to the darkening under the eyes here due to venous congestion. There might be a nasal crease. I'm not sure if you can appreciate it from this picture, but normally a bit of a transverse line across the nose from the repetitive rubbing from the itching. You can appreciate that this child has the mouth hanging open because of the open mouth breathing due to the significant nasal congestion. Then you might also get dry, cracked lips. And then over a longer period of time, there's more serious complications of actually having problems with the dentition where you end up having malocclusion of the teeth. So this ties into what I was saying earlier about it not being a trivial condition at all. As much as lots of people suffer with it and are familiar with having these symptoms regularly, it doesn't mean that it's not a serious condition that affects people's lives. So who gets allergic rhinitis? It's quite common. So varying figures depending on what sources you're looking at. So one source states that it affects 20% of people, which is 1 in 5. But there's other data that says it affects ranging from 10 to 40% of the global population. So you can appreciate from this that a vast number of people are living with this condition. Most commonly, it's seen in childhood, but also it can occur in young adulthood as well. Other forms of rhinitis might be more likely if someone develops symptoms later on in life. But if you're having onset in childhood, more likely than not, it will be allergic rhinitis. Further increased chances of being allergic rhinitis is if you also have a family history or a person or you yourself has a history of having eczema or asthma. And as I've previously mentioned, it's a chronic condition, but its severity actually varies throughout the life course. So the number of symptoms and how you're experiencing it isn't always the same. There's quite a variation. So I mentioned that it's because it's due to an allergic reaction, the allergic rhinitis, and there's different area allergens that are implicated. So we tend to classify them according to outdoor, indoor allergens. So outdoor, quite simply, it's generally our pollens, so tree pollen, grass pollen, or weed pollen. And this is something that tends to resonate quite a lot with people because there's lots of people whose symptoms they know that they tend to get a lot worse during certain seasons, corresponding with that particular pollen season. Although in some areas, the pollen seasons are actually quite protracted, so you can end up actually having symptoms all year long. Whereas with our indoor allergens, so we have things such as our house dust mite, cockroach, animal dander, so cats and dogs are common culprits, but also mold. I must mention that you can also get outdoor molds as well. So if you have a reaction or if you're sensitized to an indoor air allergen, it can be quite difficult to limit your exposure to this. So it becomes really important then to know what you're going to do to manage your condition. So in terms of making a diagnosis of rhinitis, so it's made up of basically the symptoms that you get. There will be examination, and then there are investigations that can be done if indicated. So in terms of the symptoms, so we've talked about we get the runny nose, we get the itching, the sneezing, the congestion. So we'd ask a patient about, are they getting those symptoms? How frequently are they getting those symptoms, and have they noticed any pattern? Are they particularly worse at a particular time of the day, perhaps? Or have they noticed any seasonal variation? Or have they noticed that symptoms occur in particular places? Because this might then give clues about potential triggers for these symptoms. Then once we've got an idea based on the symptoms, the history of these symptoms, we'll move on to the examination. And that's generally, you would look at the person as a whole, trying to see, are there any signs suggestive of other atopic conditions? So do they have eczema? Are there features of asthma? We've put that picture earlier about that atopic child. So we would look for any of those features being present. Then, more specifically, we would then perform an examination of the nose. And there would be looking to see, is there any enlargement, engorgement of those turbinates that we had mentioned? And we can, depending on how severe the condition is, sometimes you might quantify the amount of obstruction there is. Then after the examination, you might be a candidate for having aero allergen testing to see what it is that you are allergic to. This isn't always necessary, I must say. So there's certain patients who, based on their history and examination, you can make the diagnosis of this being allergic rhinitis. And then you can initiate a patient on the appropriate therapy. And if they respond well to the therapy, you can continue with the therapy, and you don't necessarily then have to go on to testing for certain allergens. Then this takes us on nicely onto the management. And as with all allergic conditions, we use these four pillars. So mainly the education, allergen avoidance, pharmacotherapy, which is our drugs, and allergen immunotherapy. So with regards to education, so getting a correct diagnosis is important, or getting a diagnosis at all, because there are people who live with this condition but have never, because it's been so lifelong and they've sort of normalized this condition and they never get diagnosed with having an illness at all. So getting a diagnosis is the first part. Then once you've got a diagnosis, understanding that it's a chronic condition. So this means that once you start taking your treatment, and you start feeling better because of it, and you can see that it's effective, you shouldn't stop taking the treatment, because the condition isn't then cured. It just means that the treatment is working and you therefore need to continue taking that treatment. And then understanding that the symptoms aren't normal. So I've added this part because lots of people, as I've said, lots of people live with this condition and they trivialize these symptoms. They're like, oh yes, my son, he wakes up, he sneezes a few times. Generally, that's how we know he's awake. Sneezes a few times, it gets on with the rest of his day. Or someone who's incessantly always rubbing their nose. People sort of see this as, oh, it's just a bit of a mannerism that this person has. But actually, these aren't normal things. There are people who live their lives without having such symptoms. So being aware that this isn't normal and there is treatment available for it. A knowledge of the triggers is useful because then you will likely be able to try and reduce your exposure to them. Then once you've got your diagnosis and you're understanding a bit about what the condition is, you will hopefully then be given medication. So having an understanding of what your medication is and what it does will enable you to better use that medication and probably improve your compliance with it as well. And then I've added also know how to use the medication. So this will be covered in the later session, but being given a nasal spray doesn't mean that everything is going to be okay. You actually need to ensure that you're using it in the correct way. Then when it comes to allergen and trigger avoidance, so I've mentioned that there are allergic triggers. So we talked about our indoor and outdoor aero allergens, but there are some non-allergic triggers to people's rhinitis. So for example, smoke, that would, like say cigarette smoke, that would affect someone who doesn't have allergic rhinitis as well. So an avoidance of things that make your symptoms worse would be something that you would do. I've added here not to indiscriminately get rid of everything. So just because you have allergic rhinitis doesn't mean you necessarily aren't allowed to have pets and you can't go out in the park, because not everyone is allergic to the same thing in terms of the aeroallergens. So just to be mindful of that as well when we're talking about our allergen and trigger avoidance. Then moving on to medication. So with this, the mainstay of treatment is our intranasal corticosteroids. So these are the nose sprays that people will get given to use for their rhinitis. Important to note that it takes days to weeks, it's closer to weeks for it to have its full effect. So it's not something that you're going to use. You're feeling a bit blocked, you take the spray and then you'll immediately feel better. No, it doesn't work like that. It needs to be used regularly for it to be effective. And it's indicated if someone is having persistent symptoms. So if you're having it daily, pretty much 4 or 5 days a week, you are always getting this itchy, runny nose and the sneezing, then you should be using your nasal spray every day. And I've put there again in capitals, technique of how to use this nasal spray is very important, and this will be covered later. Then something else that helps as part of the allergic rhinitis treatment is antihistamines. And this is something that everyone is generally quite aware of, and lots of people might be taking antihistamines for other things as well. So they relieve the itching, the sneezing, and the runny nose part of the allergic rhinitis, but they actually don't work well for the nasal congestion. So if you're someone who has mainly congestion, taking an antihistamine alone won't be enough. So you would need to use an antihistamine and your nasal spray. And so, as I mentioned there, so you could use antihistamines if you're only having mild, intermittent symptoms, and it's mainly on the itchy spectrum of things as opposed to on the congested side. There are also combination sprays available on the market. So this is combining an intranasal corticosteroid with an antihistamine. So you can imagine that these two ingredients complement each other. And part of the benefit of this is that because people have not instantaneous, but a very rapid onset of symptom relief, it improves compliance with using the nose spray regularly as well. So this might be indicated if you haven't done well on just the nasal steroid with the oral antihistamine by themselves. So this is just here to show the differences or the different strengths of the different medications that are used for rhinitis. So the nasal steroids work very well for the itching and the sneezing side of things and the blockage, whereas the antihistamines are more indicated for the itching and the runny nose, but not so much for the blockage. I have added at the bottom that we've got our leukotriene antagonists. So these are medications that can be used as add-on therapy for your allergic rhinitis. So this could be prescribed potentially by your doctor as an add-on if perhaps symptoms aren't adequately controlled on first-line therapy, which would be your nasal steroid and your antihistamine. Decongestant, on the other hand, are more indicated short-term for if you've got acute worsening of your symptoms, especially like we said, like the nasal congestion, because they have no efficacy whatsoever with regards to the itching and the sneezing part of things. And these generally are indicated for short-term use, so maximum for 5 days, and then you should revert back to using your normal steroids, your steroid nasal spray. So that takes me on to so the decongestants would be used in a situation like this, where you're needing rescue treatment. So this is for an acute worsening of symptoms. So you may be someone who generally has symptoms throughout the year. Then it's particular times of the year you have certain peaks. So for acute worsening of symptoms, you can use saline washouts, which is demonstrated in that bottom right picture. This again will be demonstrated a bit better for us later on. Then a short course of decongestant, as I've mentioned, and then the intranasal steroids, you might use a higher dose of the steroid during that short period of time. Again, you would do it for about 5 days, maximum 10 days maybe, and then go back to your maintenance dose of nasal steroid. Then the last part is potentially allergen immunotherapy. So I won't say too much about this because generally this is sort of for patients who have got severe symptoms that are uncontrolled on the maximum best therapy that we have, and say you've done allergen testing and you know what this person is allergic to, you might offer them immunotherapy that aims to get them to be tolerant to the particular allergen. So when you've developed tolerance, it means that you no longer have an allergic reaction when you encounter that allergen. But I've mentioned here that it's a long-term commitment. It's a minimum of 3 years of treatment, and it's usually sort of monthly injections or sublingual. So that's sort of under the tongue that it would be administered. And this is the only treatment modality that looks at potentially curing symptoms of allergic rhinitis. And I have reached the end of my talk. Thank you very much.
Thank you, Dr. Dlakavu. Very interesting talk. Thank you so much for that. Dr. Naidu, are you ready for us?
Megan, I'm just doing a check that you can see and you can see in the
That's
correct room.
That is perfect. Yes, I can.
Yes.
Dr. Dlakavu, are you going to turn off your webcam? And then Dr. Naidu's webcam is on. Awesome. Perfect. Take it away.
All right, fantastic. I'm just going to tell the audience in advance that I have terrible luck with IT, so if I have some kind of accident, please bear with me. And the second thing is that I have focused on a slightly different angle because I feel that it's the recognizing of allergic conjunctivitis that's the most challenging. And so we're going to speak a little bit more about the recognizing. There we go. Aha. So, why are we having this talk? It's quite important to know that this is a common condition. It's common internationally, and what you're seeing is a cute little eyeball, but that's showing you the proportion of patients who have allergic conjunctivitis across the world. And the warmer the color, or the closer to the yellow or the red, the more common it is. Not only is it common across the world, it's common in South Africa. We know that the environmental triggers for allergic conjunctivitis that are very common, very similar to the triggers that we've just heard from Abina, who, by the way, has set us up so beautifully for this talk. Much of what she said is going to be relevant here. That those environmental triggers are very prevalent in South Africa. It's an under-recognized condition. Because it's under-recognized, it's under-treated. And because it's under-recognized and under-treated, it's underappreciated. And patients with allergic conjunctivitis are very often expected just to suck it up and soldier on. And that's not actually a very helpful way to go forward. My notes. Alrighty, I'm just going to put my camera off for a second. We're just having some challenges. All right. So, there are three little conditions that I want us to think about. So they're going to overlap, and you're going to see in a while how we've done that. So there are conditions that are common, very common, and less common, but quite severe. And then we're going to talk about medical conditions that involve the eye, allergic people who also have eye symptoms, and then a smaller group of people who only have isolated eye allergy that is less common, but quite a severe phenotype of this condition. And because my aim is to help all of us recognize allergic conjunctivitis and manage it more effectively, I really did want this webinar not to replace that healthcare worker interaction, which I think is so important. So, medical conditions that have eye symptoms, and I would like to credit our colleague Dr. Sobi, who couldn't join us today but has been active in the AFSO series in 2024. Eye infections are quite important. So you can have bacterial infections that are characteristic. They've got a sticky yellow or green discharge, often with one eye first, often intense discomfort in the eye. And you can have viral infections that start with a more watery discharge, often with cold symptoms, and are highly contagious. The reason I mention them here is because there are many reasons for having red or itchy eyes. And some of them are more serious. Eye infections are common, and over-the-counter drops may be suggested to you, but steroid-containing drops can be very, very dangerous in this condition, particularly viral infections with herpes, where a steroid drop could make the infection spread rapidly and, in fact, potentially damage your eye. The next issue that I want to raise is tuberculosis. We have incredibly high rates of TB in South Africa, which can present with eye symptoms. And the picture that I have up here on the screen is actually one of the easiest ways to diagnose TB. So I don't want us to think about common things, camera back on, which are also very relevant. I'm going to try and put my camera back on. All right. Alrighty. So as we go along, we now move to another very important conditions where you have a medical underlying condition with eye symptoms. On the right, we have a very common phenomenon, very common. It's common in all the adults. There's a gritty feeling in the eye that worsens with screen time or wind, and we call that dry eye, which is a very simple condition. It requires lubricants, ocular lubricants alone. And on the left, we have a group of conditions called autoimmune diseases. These run in families as well. They tend to be more in women than in men. They typically have arthritis and some kind of rash, but they can present in many ways, and they can be quite a puzzle to work out. And I have personal family experience here, which is why I wanted to include it in this talk, of a family member who was diagnosed by the eye specialist with a potentially life-threatening condition. So while we are speaking about allergic conjunctivitis, we don't want to miss other important things that would also need effective treatment. Now we're going to move on to allergic rhinoconjunctivitis, and I do want to remind you that Dr. DeCarver's talk has actually set us up beautifully for this, because many of the things that she spoke to are directly relevant here. We know that there's an eye-nose complex. These two organs are very close to each other physically, and actually very close to each other in terms of how they interact with the world. They are highly exposed to the outside world, and it is the epithelium that is exposed. So all the immune mechanisms and immune symptoms that were described in the nose play out in the eye as well. The vast majority of people who have allergic conjunctivitis have allergic rhinoconjunctivitis. And they will be atopic individuals, possibly with other atopic conditions, allergic rhinitis, allergic conjunctivitis, possibly asthma, possibly eczema. And the key with this group of individuals is that we treat the whole individual. The severity of your different conditions may not be equal, and it's really important to unpick condition by condition and control each of them as best as we can, because quality of life is directly related to the sum of your symptoms, not your conjunctivitis or rhinitis or asthma alone. The symptoms of allergic rhinoconjunctivitis, and again, you will be struck by the similarities to the symptoms that you heard in the previous talk. Itchy eyes, there's redness of the eyes, though usually both eyes. There's often a burning sensation, but critically, there must be no eye pain. Photophobia is very common. Watery discharges are very common. Again, I'm going to highlight this. There must be absolutely no visual loss or effect on one's visual acuity, but there can be some eyelid edema, which is a fancy way of saying some swelling. The picture of allergic rhinoconjunctivitis is one that you know. It's the person who's sneezing, who's got these little creases over the eyes, and of course the incessant rubbing. Now there are two patterns of allergic rhinoconjunctivitis which we will speak about, and you will recognize them again because these are the concepts that come up with allergic rhinitis. There is the pattern on the left, which is associated with a shorter spring, where you move out of a cold, long winter. You have a spring arrives, you have a rapidly escalating pollen count, and you have a short period of intense symptoms that are strongly associated with rhinitis. This lasts for days to weeks, and I lived overseas when I was a young doctor, and this we can really call that European pattern, because that is the weather pattern that they have, and that is the allergen profile that they have. South Africa has very much a different climate, and we have very different growing seasons. So we have year-round exposure to allergens, and that waxing and waning picture that was described in allergic rhinitis applies here as well. The symptoms tend to be milder but are more chronic. It can be indoor allergens as well as outdoor allergens that are responsible, and the eyes and vision must be normal. And I stress this because as we move to the next slide, you will see why this becomes important. The third group of conditions that we need to keep in mind is patients who possibly have no other allergic conditions or have minor allergic conditions where their symptoms are predominantly eye-related. So they have predominant or isolated ocular allergy. They have distinct little patterns with a little bit of overlap, but they are in general much less common. Previously, it was thought that they overlapped minimally with atopic conditions, but that is becoming challenged. I think people who worked in this field thought there was a distinctly north and southern global phenomenon, but it turns out that the global north and the global south are actually much more similar when it comes to allergic conjunctivitis than we had thought. This group of conditions is far more serious symptom profile. There can be corneal damage, and most importantly, there can be visual impairment. In this group of conditions, team management is the key. There needs to be a team of healthcare workers, and absolutely, it must include an eye specialist. The medications, and we will not discuss them in this webinar, are much of a stronger efficacy. They have a stronger side effect profile as well because they are balanced against a group of symptoms that are much harder to control. I'm going to show you some pictures now, and you'll start to see immediately the differences between the pictures that we saw before of allergic rhinoconjunctivitis and these conditions. The most important one, which is very common in prepubertal children, particularly Black African children in this country, is vernal keratoconjunctivitis. You can see that there's one type that presents with these almost like these little swellings on the inside of the eyelid. These cause friction and cause damage. Sorry, I'm using these three. The 1, 2, 3. You can see these little swellings that are highly irritating to the cornea, cause intense itching, intense discharge, and are can be quite challenging to control. And then we have this other form of VKC that has these little, almost like jelly-like bubbles around the end of where the colored part of your eye meets the conjunctival surface. This is incredibly, it's a very symptomatic form of allergic conjunctivitis, often with a thick gray, sticky, tacky discharge, and it's a very characteristic look. If you or any of your family members have something that looks like this, you must please access healthcare urgently, because this is one of the forms of ocular allergy that can potentially affect your vision. The next condition we will move to is called atopic keratoconjunctivitis, and this again has a typical band of people that it affects: slightly older, middle life, or slightly into the elderly. It's strongly associated with people who have eczema. The picture on the left is of a more advanced stage, and you'll see that the eyelid has been involved and that there's loss of eyelashes. There's this mirroring or glaze of the cornea that you can see here where everything looks dull, and you can see that while it is red, there's a different pattern to the redness where the vessels are starting to become obvious. Even on the other picture that's of a much milder expression of this condition, you can see that this is not non-specific redness of allergic rhinoconjunctivitis. This is the actual vessels that are swollen and pulsing with blood, and that it's these vessels that actually mediate the long-term damage and visual impairment. So if we can move on to treatment. And I have a little table here that we're going to go through different types of conditions that we've spoken about and different kinds of medication options. You'll see what runs through all of them is allergen avoidance if possible. This is always allergen avoidance if a known allergen exists. The triggers for doing allergy testing is usually the allergic rhinitis. And the techniques we would use are very similar. It would be skin prick testing and the traditional things that we are used to. Localized eye allergy tests are possible but are quite tricky to do, and so mostly we would do the general things that would indicate an allergy testing schedule. Eye hygiene is the next important thing to think about because they run through all different types of allergic conjunctivitis, but they are actually, we don't think about it. Things like making sure that you have clean hands when you handle your eyes, rinsing your eyes with cool water, which helps to literally to ask to assist your eyes in flushing out local allergens and improving symptom control. Cool cloths and compresses. These are also can be very helpful in these non-specific symptoms, particularly things like the photophobia. Sunglasses, again, to the photophobia, sunglasses can be a physical block to wind, which can be a trigger. It can be a physical block to allergen exposure, which can be a trigger, and it can blunt out UV exposure. And sunlight can be, the photophobia is a very important trigger. Now, it's good for us to think about that and think about how many of our activities of daily living can be affected by somebody who's struggling with light sensitivity, an adolescent or a child or adolescent. So much of their schoolwork and their vocational training involves screen time. And for a busy adult with a life and who's got a family and chores to do, the actual mechanism of driving and transport and safety while you are doing these things is quite important. Other things that are quite simple and easy to do is to think about tear substitutes. Many of the eye symptoms revolve around grittiness and a feeling of almost like sand in one's eye, which can be mitigated by tear substitutes. And then it's quite important to think that we must treat all other allergic conditions really well. For seasonal and perennial allergic conjunctivitis, the key is actually treating the allergic rhinitis optimally. And in VKC and AKC, we would treat any other allergic conditions that happen to be present with VKC, and then AKC, we would have to treat the eczema very well. When we go on to specific pharmacotherapy, please look out for combination treatments if you can. And they are relatively newer to the markets than the older drugs that we will know. And they are mast cell stabilizers and antihistamines, and they really do work beautifully. These are treatments that are delivered directly to the eye that allows us to use smaller doses, decrease the side effect profile, and get the maximum effect at the lowest possible dose. What is very important about this slide is what is not on the slide. Absent here is the whole class of over-the-counter vasoconstrictors. These are the eye drops that you can get from a pharmacist. And give you short-term defect. You can put them in the eye, you feel better, and then within a few hours your symptoms start to recur. Now, these are the phenylephrines, the oxymetazoline, the naphthalene. These are all temporary agents which cause short-term relief, but once they wear off can have a rebound effect. So the most important thing about this slide is which agent we would like you to avoid. So our take-home message for this condition is that eye symptoms are common, and that they are not always allergy related, and that if you are concerned about any of those more severe forms of allergic conjunctivitis or non-allergic conditions, please think about scheduling an appointment with your healthcare worker. But that eye allergy is mostly related to nasal allergy for very obvious reasons, because of their proximity and because of their similar structure and similar immune mechanisms that are in play. When you're trying to diagnose an eye allergy as a healthcare worker, it will be more look carefully at the look of the eye, listen carefully to the symptoms that the patient is telling you, and feel to have a very good examination of your patient rather than falling into immediate testing. Treatment is mostly delivered directly to the eye. As always, with all allergy conditions, we want to achieve the maximum amount of benefit with the minimal amount of medication. And the last thing is that because these conditions tend to travel in packs, we must treat the whole person and not just their eye. Thank you so much.
Thank you, Dr. Naidu. Yet another interesting talk. Okay, Dr. Duvall, you are up next. I'm going to make you the presenter. Dr. Duvall, are you there? Amazing stuff. Awesome. I do encourage the audience to continue posting any questions in the questions tab. Oh, we've lost your screen sharing now, Doctor.
Hi, Mix.
Hello.
Sorry, I just want to get my things ready here. Good. Can you see it now?
Yes, we can. That's perfect. Thank you so much.
Okay, excellent. All right, thank you so much for the two previous speakers. They've really set the scene quite nicely, and I think there's some very important messages that we got from our previous two talks. I think first of all, remember that not all problems with rhinitis is necessarily allergic rhinitis. We've had one question in the question pane about menopause. That's an important non-allergic rhinitis cause. And then also it's important to treat the eye when you have allergic or allergic rhinitis symptoms, because the two often goes together and can be a serious or detrimental problem in patients with allergies. So I'm going to quickly give you uh, um, a few patient resources. It's going to be a fairly quick talk where you can find information on allergic rhinitis, on any allergies for that matter, and also allergic conjunctivitis. So first of all, I just want to quickly recap or revise what AFSA stands for. AFSA stands for the Allergy Foundation of South Africa, specifically tailored to South African patients, specifically for South Africa or written by South Africans. There's so many information on the internet available nowadays, on social media, and I think it's very easy to get lost between all of this information that's been spread on the internet. I think what's also important to remember is that our allergens or our allergy profile or patient profile is not necessarily what people sees overseas or what people encounter in first world or developed countries. We have a unique sort of micro or biome of plants and weeds and trees in South Africa that is quite unique to South Africa. So it's important to follow or to look for trust or to look into trusted sources of specifically allergy or South African tailored information. So the South African Allergy Foundation was first established to create awareness, but it's really been grown now recently or throughout the years to advise and educate patients not only on allergic conditions but also immune conditions like, for instance, immune deficiency. It's also important, or it also was established to promote responsible allergy and medical care, and it really assists in advocacy or advising and fundraising for professional development, specifically in allergy. And note, we are a non-profit company. So our website is, like I said, or like Mex has highlighted, the Allergy Foundation of South Africa can be found on www.allergyfoundation.co.za. I think what has been highlighted previously is that it gives you a nice tool to search for professionals or allergy professionals in your area or in your province. I've had a few patients recently emailing me and asking me, where can I find a doctor near me? So please make use of that facility. It highlights doctors, or it lists doctors that are specifically not necessarily allergy specialists or subspecialists, but there are people really dedicated and people who are really interested in seeing allergic patients. And also their expertise and where can they be contacted is on that specific areas of the website. There's regular social media newsletters that's been published, including support groups on Facebook that's really picking up. Allergy blog posts can be found. And I think it should also be highlighted that the content of all these publications and newsletters and social media posts are not intended to be a substitute for good medical professional consultation. You'll see the few questions that I've answered this morning is repeatedly saying, please chat to your healthcare practitioner or your doctor or your sister for that matter, and just get professional help. It's very difficult to treat a patient without a good physical examination and a good clinical history, especially when it comes to allergy. I think one of the things that I found or find most useful on the allergy website or the AFSA website is the downloadable allergy information. So there's really, in a busy practice, there's really not a lot of time to educate patients unless you let them come back after you formally made the diagnosis. But it's important, once you've made the diagnosis of allergic rhinitis or allergic conjunctivitis, it's important that it's not just a script that you prescribe to the patient. So often this is where our work starts, when the diagnosis has been made. And now the patient needs to be educated on what exactly the disease is, what the treatments are, and what your patient is allergic to, and how to avoid these allergens. And then obviously make sure your patient is adherent and uses his medicine daily. So in a busy practice, that can be a challenging task. We often do not have time for intense education sessions. And that's where downloadable allergy information comes in very handy. It comes in in PDF format. You can literally ask your receptionist or to print or to give an information sheet to a patient. The patient can read it at home, and then they can ask questions on it during a follow-up consultation. So there's virtually all allergic conditions are now covered with downloadable PDF allergy information. So this is just an example of how the allergy rhinitis leaflet looks. So there you can see it basically gives you common symptoms and signs. It tells you about triggers or maybe allergens and irritants that can cause it. And then it will go on and tell you about what the condition, what the treatment would be, and possible other treatment modalities that is available for South African allergic rhinitis patients. The AFSA website also gives you a nice link, or also elaborates on allergy safe and AFSA approved products. So remember, these products, sorry, that should have been just one F. So the AFSA approved products are basically Allergy Foundation approved products that has been evaluated by the panel of experts on the Allergy Foundation or in the Allergy Foundation, and it gives you nice reviews on specific products. It's really not there to promote any specific products or to advertise it, but it really gives you with so many products that is on the market, it really gives you a guidance on which products has been looked at on the AFSA panel and which products can be used. So there on the left hand side, you'll see specifically for allergic rhinitis sufferers, we do advise using a good or a trusted vacuum system that has a HEPA filter in it. So those two devices on the left hand side has been specifically reviewed by the AFSA panel of experts. And on the right hand side, you see air purifiers that also has been given. Once again, remember, it's not to promote any specific product or to sell it. It's just been looked at from and given the AFSA seal of approval. The Learning Academy is picking up very fast. It's specifically aimed at healthcare professionals or doctors, nurses. We have had occupational therapists, even physical therapists that attend these courses. And it's really to help people understand allergic conditions better. And it's really to help doctors also make the diagnosis and treat their patients more adequately. So it runs throughout the year. There's currently 8 main topics that are covered. We've already completed the 24th of May. We've completed the allergic rhinitis masterclass. And it's really available to all doctors and even pre-graduate students. So if you are a medical student or if you are a registrar, doesn't matter which subspecialty you are in, I think it's important to take or look at these master classes and see if you can't attend one or two of them. It's really been the feedback has really been incredible from our doctors and even our nurses. So then, as Dr. Abina highlighted, remember the technique of using your nasal spray is important. We've had a few questions this morning, people saying they've been using nasal rinses and nasal sprays. They're not sure if they've been using it correctly, and it seems like they are not really effective. I think when it comes to technique, it's very important to know how to use these devices and medicines. Otherwise, they're not going to work. And actually, they should work if you use them correctly. So let's just take a look at the technique of using a nasal spray. So that's typically your intranasal corticosteroid nasal spray. Remember, that's a mainstay of allergic rhinitis treatment. What I normally advise patients is to use their saline spray, just a plain, normal saline spray before they administer the intranasal medicine. So it's important that these saline spray, or the reason why we advise that is, first of all, it clears your nasal passages. It takes away all the allergens that's been deposited on your nasal mucosa, and it also helps to wash away all that snottiness from your nasal mucosa. So it actually cleans your nose out, it moisturizes your nose, and then it will help actually your nasal spray to better deposit or to better penetrate your nasal mucosa. It's important after you've used your nasal spray to blow and dry your nose thoroughly, because remember, you're not going to do it afterwards. After you've used your intranasal spray or corticosteroid spray, you're only going to use it before the time. So now you blow and dry your nose out. Make sure your nose is nicely clean and dry. Shake the bottle well before you use it. That's the bottle of your intranasal corticosteroid spray. And then we ask patients to bend slightly forward before they administer it. So the reason is that you aim for the back of your head and that your nasal spray actually moves in a circular or a flushed motion throughout your nasal passage and your nasal cavities. So it's going to make sure that your nasal spray actually penetrates the whole nasal cavity far better. It's important not to spray towards your nasal septum. So that's this middle part of your nose. Otherwise, your nasal spray is just going to basically run out of the front part of your nose, and that's not really going to sit where you want it to work. And the other problem is that we often see in children, if they spray repeatedly towards the nasal septum, this middle part of your nose, it can cause a bit of local irritation and then cause a bit of nasal bleeding, which will definitely lead to patients not using their nasal spray and having sort of an unpleasant feeling and attitude towards their medicine. So aim slightly to the side. There you see that picture on the bottom right. That lady is aiming slightly to the side, and she's also aiming to the back of her head. So that's actually the correct way of using it. A common mistake that I see people make is they sniff. The moment they've sprayed their nasal spray or injected their nasal medicine, they start sniffing. That's actually not what we want. Otherwise, all that medicine is going to run down the back of your throat and not really sit on the inside of your nose where you want it to work. And then obviously you should spray in each nostril separately. After you've done that, lift up your head, look straight ahead, and then pinch your nose and hold it there for 10 seconds. So that will really help your nasal spray to work, or have long enough to work on the inside of your nose and sit on your nasal mucosa. And then please remember not to sniff, not to wipe your nose, and don't blow your nose afterwards. Otherwise, you just blow all that medicine out of your nose, and it doesn't really have time to work. What about nasal rinses? So nasal rinses works very well to clean your nasal passage and nasal sinuses of all the allergens and nasal snottiness that makes you feel congested. And like I said, it also helps your intranasal corticosteroid to better penetrate your nasal mucosa. There are commercially available mixes which works very well. Unfortunately, it can be a bit expensive if you use it over the long run, and that's why we also have a home mixture of that that you can make at home. So basically, in a clean container, you can use 3 teaspoons of iodide-free salt and 1 teaspoon of bicarbonate of soda. So you mix those two. And then you add 1 teaspoon of this mixture to about 250 ml of lukewarm distilled water. Please remember, it should be cooled down. So after you've boiled it, you should be cooled down. And then you can either use an ear bulb or a commercial device, which is fairly easily available or commercially available. You draw that up into your device, you lean over the sink with the head held sideways, and then insert the mixture into the top nostril, tilt it, and it should then come back to on the other side of your nasal passage. So in other words, you turn your head slightly to the one side, use the top nostril first, and then after you've injected that in the top nostril, you'll see water or that solution coming out at the bottom side of your nose. And then repeat it on the opposite side. So it's very important to use these medicines correctly and use the correct technique. Otherwise, it might not be as effective. And then, like Megan already has highlighted, we really encourage people, if you do not have access to any spacer device, to use or look for the AFRI spacer. So remember that when it comes to asthma treatment, it's important, once again, like allergic rhinitis treatment, to use the correct technique when you use your pressure metered dose inhaler or your asthma device. Otherwise, the medicine is not going to be deposited in the areas of the lung or the nose where you want it to go and sit. So then the whole exercise is actually a bit futile. So remember, the AFRI spacer is now available at Dis-Chem Spar and some selected pharmacies. It comes with a mouthpiece, that little blue thing there at the top. And it also comes with a mask for smaller children. And it can even be bought online at www.afrispacer.co.za. So it's fairly cheap. It's around 100, 110 Rand when you include the valve. And like I said, it's an absolute must for patients with asthma sufferers who cannot use their PMDI adequately. And it also improves their asthma control itself. Then my last slide is just to encourage you to please get involved in the doings of the Allergy Foundation of South Africa. We are there to advocate. You can also get involved in advocacy. We publish clinical trials that are available at some research institution on various conditions like atopic dermatitis and asthma and so on. There is an option for you to do donations. We do fundraising. There's various school projects going on. And we're even planning a lot of exciting stuff for World Allergy Week, which, by the way, is from the 29th until the 5th of July this year. So it's around the corner. And please sign up for any newsletters and updates on our website. And there's the link. And then you can receive some exciting newsletters, or all our exciting newsletters and updates, and keep up to date with happenings around the allergy or around allergy topics in South Africa. Okay, thanks, Mix, and thank you all for paying attention.
Thank you so much. We've come to the end of the presentations for the day, and we've got a little bit of time carved out for questions. So I'm not sure if the panel has, I do see that a lot of questions have been answered. I'm not sure if the panel perhaps wants to just have a quick look and see if there's anything that is worth discussing in a quick panel, that we can move through some of the unanswered questions before we get to the last part of today's session, which is obviously announcing the winners of the prizes today.
Yeah, I'm just going through the question pane here, Mix.
Okay, sure. So while Dr. Wiley doing that, I'll just put up
yes.
the slide for our next session, just so that anybody who's obviously interested can get those registration links, but you are welcome to go right ahead and answer a few of the questions if there are any.
All right, so there's one remark that says, "Thank you, doctor. I sniff and blow the nose drops. Appreciate the info." So it's very important try not to sniff. I know in children it's often difficult, but try not to sniff. Otherwise, you're going to let all your nasal spray land up in your throat, and that's often why people complain about the nasal spray having a bad taste, is because too much lands up on their throat or inside their throat. Um, I just see there's one question. She was actually discharged from Red Cross in December last year. Her doctor was Professor Levine. She's now 13. What is the next step for me? The last eye test, they asked me if I had an accident or was the eye damaged. Unfortunately, we do not really have enough information to answer this question. So I suggest maybe look or maybe make an appointment at the Red Cross again. I mean, 13 years still falls well within the pediatric group, and maybe an appointment at an ophthalmologist is not a bad idea. I'm a non-smoker, so does it affect me if my partner smokes? That's a very good question, and that's actually also it also has some relevance to children where parents smoking. So we're talking about first-hand smoking. So that's basically where you smoke, and that's your first-hand smoking that you are inhaling or experiencing. Then you have second-hand smoking, and that's usually something like in a car situation or in a certain confined living space like a living room or bedroom. And then we talk about third-hand smoking, which is basically that chemicals and that toxins that goes and sit on people's clothes and on surfaces like furniture and even like blinds and curtains, and that can also be detrimental, and that can also has a negative effect on allergy sufferers. Remember that smoking is an irritant, it's not an allergen, so it can really affect anyone that has a sensitivity in their nasal passages or their chests. So yes, the short to your answer is yes, it can definitely affect your partner that is smoking, can definitely affect your nasal condition and your nasal symptoms also. And we generally advise people to completely stay away from all forms of smoke if they are allergy sufferers. Is long-term nasal spray harmful? Spray is harmful to overall health. I think we've had a lot of questions on this morning. Is it safe to use my nasal spray for a long time? And the answer is absolutely yes. It has been shown in studies that it is safe. Obviously, you need to keep in mind when a patient is already using is using a lot of different sources of corticosteroids, like topical corticosteroids, and asthma symptoms, to keep an eye on the amount of corticosteroids that you are exposed to. But generally, it's safe to use it. What is the difference between allergens and irritants? I think that's already been answered. Allergens is basically certain conditions that causes IgE antibody production and causes your allergies to flare up, where irritants are basically anything from cigarette smoking to fumes and so on that can cause nasal symptoms. So basically anyone can be susceptible to irritant-induced symptoms, whereas a selected group of patients or allergy sufferers can have symptoms when they are allergic. I see there's a question. Even when I have no blob in my infectious left nostril, I still find that most of the time no mucus are released from the nostril when I blow my nose. How can I overcome this? I'm not sure how to answer this question. Can you maybe just elaborate a little bit on what you're meaning there? Then we can then I can answer your question more accurately. This is a very good question. Is it possible to outgrow your allergies? And the answer is absolutely yes. There are numerous studies that has been shown that you can outgrow your allergies, specifically asthma. But unfortunately, allergic rhinitis is probably one of the conditions that will stay to you forever. And remember that even your allergies or a condition like asthma may be dormant for years, and then as an older adult, it may flare up again, or in the working environment, which is called work exacerbated asthma. So some allergies, it's difficult to predict. Some allergies are definitely outgrown. Typically food allergy is a good example. Maybe asthma, but allergic rhinitis are often not outgrown and may flare up later. And then there's a good question, is smoke from braais also harmful? And the answer is yes, that falls under your irritants. So it can be harmful to allergic sufferers, but it can also cause exacerbation of non-allergic symptoms or non-allergic patients. So yes. Then there's a good question. I developed allergies later in life, where as a child, I was not allergic. What can be the cause of that? So that's a typical symptom that we see, the allergy in the adult, or first-time allergies or allergies in adults. So it all depends. Often what we see in adults is pollen food allergy syndrome. So that's where a patient develops, or over years has been sensitized to certain pollens, and then the immune system gets a bit confused on what is a pollen and what is a food. So we often see it in food allergy patients, or patients or adult patients developing food allergy for the first time. So it can be sort of in the setting of a pollen food allergy, where you first were allergic to pollens or sensitized to certain pollens, and then develop an allergic or food allergy later in life. Does any one of the other speakers one? Maybe Sharani, you can answer this one. My son has these blue, I assume blue discoloration under his eyes all the time. Can this be allergy related?
Hi, Peter. So the kind of characteristic discoloration is kind of a hyperpigmentation or dark rings under the eyes um, that are often associated with almost like exaggerated wrinkles. We call them Denny Morgan lines under the eyes. They are and Shireen Nicole, I don't know how old your boy is, but in infants, babies under 2 or 3, there are some other conditions that can also present with discoloration around the eyes that I would be hesitant to say can only be allergy related. All of us, Dr. Devan, Dr. Tlakava, and I, we are pediatricians as well. You know, allergy is one of our things, but we all started as pediatricians. And from my talk, you'll see that I like to keep an open mind about what could be causing the symptoms. So there are other things, and I would hesitate to have too strict an answer to that. And it depends on the baby's age. I'm just trying. I see that there's an there's an answer already, but I would encourage you to have a healthcare worker evaluation, and like the same thing that I said, look, listen, and feel. They would need a proper history and a good examination of your boy. If he's little and has deep discoloration due to nasal allergies, those will be very obvious to their eye as they look in their nose, and then that question will be answered for you. And if they don't find very severe nasal allergy, then they are in the right position to look a little bit further. Please if you've got a follow-up question, pop it into the chat.
And I see there's also a question, I'm not sure if this one has been answered, Sharani. Can allergies be hereditary?
Haha, hereditary. I see that there's a follow-up about the little boy. He's 6, and I think I still would suggest that you take him in for a healthcare visit. In terms of hereditary, there's 2 components to that. family history and the shared genetics that you inherit from your family are incredibly important. There's a little bit of a to and fro where the maternal inheritance is slightly more significant when it comes to allergies than paternal, but hereditary, definitely yes. But there's a second component to that, and that's the whole field of what we are as allergists, what we are now just starting to discover, which is what we call epigenetics. So we know that your genes produce proteins, the proteins become used to make up your body and how your body and your immune system works. But we are starting to understand that the things that happen to you very early on in your life, before you were born, and in that first year or two, actually really affect how your genes speak and what kind of person they shape. So one, there's a genetic component to allergies without doubt. The studies have shown family history very definitely to be important, but early life exposure is also important. And we say this because early life exposure can push you towards being more likely to be allergenic. And what we are hoping to emerge from all of our research is it can also tell us what we can advise people to do to make their children potentially less allergenic. Dr. Duval has already touched on things that are important. Smoke exposure, tobacco smoke, environmental tobacco smoke is one of those things that push one towards poor lung health, not towards good health. But there are many things that are in that same vein, that those are epigenetic things that can improve your chances of being tolerant or non-allergenic. For example, many years ago, we would have told parents to avoid potentially allergenic foods for long periods of time because we were afraid of food allergies developing, where that has turned out not to be good advice. So the hereditary is a yes, but early life exposure is also important, and we need to try and provide as allergy friendly an environment for our young babies from early on in their life, so that they, whatever tendency to become an allergic or atopic individual is minimized. I'm hoping that that is helpful to Liesel, Stace, and Kika. And if they have any further follow-up questions, you can just pop them in the chat. Shirley Nicole has asked a very interesting question. What can I do as a parent to prepare for change of season and for allergy flare-ups? That is a very, very good question. All of our speakers have spoken about the need for regular therapy and how controller therapy, be it for asthma, for allergic rhinitis, for allergic conjunctivitis, does not have a quick onset. If we look at the international literature and if we know what happens in our consulting rooms, would say that probably about 40 or possibly even 30% of our patients take their medication regularly as prescribed. Probably the best thing that you can do in the run-up to spring is to do a clear out of your medicine cabinet. Look at all the stuff that you have, check out the things that are expired, make sure you have everything, and make a conscious effort to be more regular with your medication. And I don't say this in a way to judge it at all. Dr. Duval, Dr. we've been in this business for a while, and we are all, we all have our own health challenges as well. So it's difficult. It's really difficult when you have a family and you've got kids and there are 1,000 things to do to remember about meds every single day. So the best thing that you can do in the run up to spring is to be consistent with what you have. If you are failing on what you have, then it's time to speak to your healthcare worker about step-ups. But usually the best thing to do is to get into your rhythm of regular use way before the season starts. And from a healthcare worker perspective, what I always tell when we have these sessions for healthcare workers is don't try to cut medication before the season in which people flare. If you're going to decrease medication to the lowest dose of controller, do it in a good season when patients are least symptomatic. So for example, it's the weather has changed in Cape Town and we are into our winter season, and following that we will have our spring, which is more a flare up for people with nasal allergies. So I personally wouldn't make any medication changes now because they won't work. So it's a sensible practice. and to make sure that you are as regular and as adherent with your medication as you can be.
I see that we have a rephrase of the earlier question regarding the blob or the infection in the left nostril. So I'm not sure who's going to pick up that one. Dr. Deval, you had originally started reading that question, so I think there's a bit more clarity now on what the ask was trying to communicate.
Oh, yes. I see. I seasonally develop a blob or infection only in my left nostril, so it's on the one side. But even when I have no blob in my infectious left nostril, I still find that most of the time no nasal mucus are released from this nostril when I blow my nose. All my nasal mucus, when I do blow my nose, comes from my right nostril, even though my left nostril is clear. That's a very good question. I think what's happening here is maybe your left nostril is actually very blocked and there's no nasal flow or no secretions that can get out of there. So I think if I would be safe, I think a safe question here is get a doctor to do a good ENT examination. Remember, there could be other reasons for that left nostril to give problems. You can have either a structural problem where the nostril is skew, or you can even have something that we call a nasal polyp or some growth in that nostril. So it's very difficult to answer your question by just the information that you give to us. I think a doctor, any primary care physician, doesn't necessarily have to be a specialist. As long as someone just do a good ear, nose, and throat examination on that left nostril, and hopefully they'll pick up something from there. Maybe just a question for Abina. Abina, are you there? Does a fan in the summer in the kids' room make them sick? A lot of doctors have said yes, and others have said no.
Yes, I am here. So I wouldn't necessarily say that the fan makes them sick. So what gets spoken about a lot with the allergic rhinitis, or the concern can be the humidity. And generally you're trying to not have humid conditions, because if children, for example, are allergic to house dust mites, this can, or if there's mold, for example, that they're allergic to, this will sort of thrive and be worsened if there is humidity. But I can't say that the fan, for some people, they find that having a fan dries the nasal membranes, and then that can make things a bit difficult for the children in terms of their breathing. So I'm not sure whether the answers you're getting, the differences in the answers, are because the people are looking at different aspects about the fan. So are you using the fan, is the concern about for the kids the fact that they get dried nostrils, which some people do experience with having a fan, or is the concern about the allergens that are in the environment that can potentially be made worse by having or not using a fan in this place? I feel like I'd need a bit more of a question, more information to answer Cherie properly. In what way does she say make them sick? I don't know if that
Yeah, I
makes
think
sense to you, Cherie. If you could, yeah.
yeah, I think you've answered that question. I think it's more humidity and that I think she's probably referring to nasal symptoms as sick. Maybe just to link on to that question, there's the next question from Sharon. She's asking, does a purifier help if your partner is a smoker? Do you also want to tackle that one?
Can I please send it back to you? Because I'm not sure when we say a purifier, so that's not a humidifier. So, or is it a dehumidifier? I'm not sure what a purifier
Yeah.
actually would be.
So we do advise air purification for some of the irritants and then some of the allergens, like cleaning house dust, for instance, for house dust mite allergy. But I think in a setting where you have a purifier helping your partner smoke in protecting you against your allergy or nasal symptoms, I don't think a purifier is going to help a lot, because remember that first, second, and third hand smoking, there's just too many avenues for that allergen or irritant to get into your nose. I don't think a purifier is going to do the trick, unfortunately, Sharon. So, yes.
Um,
Um,
uh, Peter,
yes.
can I just interject there for a second? I
Yeah, sure.
do, I feel for Sharon because I can imagine that this must be challenging. But when we look at environmental tobacco smoke, there is no allergic condition that it does not affect. So the quality of life and symptom scores for asthma go down, for allergic rhinitis go down, for allergic even eczema scores. So that it is a complex product that is delivered when you are smoking is without doubt, and it really is. The inflammatory cascade that it sets up in your own body as a healthy person is immense, and as a person with asthma or that, it is quite significant. So while the questions about purifiers and all of it's good for us to talk about this, but I think we would be remiss if we didn't remind you that the smoker themselves is having negative life events and health events, and that we really mustn't underplay the role of encouraging them to decrease their smoking and encouraging them possibly to enroll themselves in a smoking cessation program, of which there are ones. There's adjuncts like there's gums and patches and there's programs where people really do help themselves and are helped by their peers to decrease the amount of tobacco smoke that they consume themselves and that they produce into the air. I see that you're looking for a workaround, but in as much as you are being affected by the smoker themselves is being affected, and we really must encourage them to be mindful of the effect on their health, effect on all of the people in their surrounds, and offer whatever non-judgmental support we can. Being overly critical and attacking is not helpful, but constructive and supportive suggestions can sometimes be useful.
Okay, I think that we actually are approaching the end of our session today. Thank you so much for the for answering those questions to the panel. Thank you so much. Are there any more that you perhaps feel warrants a minute or two, or can we proceed with the wrapping up of today's informative session?
See, there's just one question, Mex, about a persistent postnasal drip, no nasal discharge and sneezing. What could be the cause despite the regular use of a nasal spray? I think it's important to also find out how old is the patient that we are talking to, because different ages might complain about different symptoms, including just a postnasal drip. So that typically is a symptom of their older nose. So in that case, intranasal corticosteroids may still help, or even something like intranasal anticholinergics might be helpful. That's just
Okay, awesome.
good.
So I think that we've actually come to the end of today's program. Before I move on to announcing the winners of the prizes today, I just want to thank our panel of experts for time and dedication, for answering all of these questions, and also to the audience for attending and for the patience for staying with us for the full duration. A reminder that you will receive a link to the recording of today's session by Monday. Please just give us 2 days. The system does need to process everything. So anybody who registers for these allergy education workshops will receive the recording of the session to the email address that they've used at registration. Just a reminder about our website. A lot of the information that we discussed today can be found and is free to access and download via our website, which is www.allergyfoundation.co.za. And then congratulations to our lucky winners today. Shamla Goundan, you have won the Mrs. Martin's Beet Allergy Starter Pack, and Laverne Duplessis, you have won our Salix hampers. These products were generously sponsored, and we do encourage you to sign up for the next session taking place on the 19th of July. For more information, please feel free to contact admin at allergyfoundation.co.za. Thank you so much. We also thank our sponsors for making this event possible. Have a wonderful weekend further, and we look forward to seeing you at the next one. Take care. Bye-bye.